Okay, so now we will look at the cartilaginous joint. So this is our second category in the structural classification. So as the name would suggest, a cartilaginous joint is where we have bones that are united by cartilage. So with the fibrous joints, they were united by a long run of fibers. Here, cartilage is the unifying connective tissue. Now, like the fibrous joints we looked at, cartilaginous joints lack a joint cavity. That means there isn't a gap between the bones and the cartilages. It's all one continuous thing. And this is different from what we're going to see when we look at synovial joints, where we will have cartilage, but it's just going to be on the bone ends, and there's going to be a fluid-filled gap between. Here we don't have that gap. There's no joint cavity. Instead, we're having bone, a portion of cartilage, and then the next bone. Okay, so because again, we have a connective tissue running all the way through that joint, these cartilaginous joints are not highly movable. Now, there are two types that we're going to look at. The first is synchondroses, the second are the symphyses. Okay, let's look at synchondroses first. Okay, I'm just going to hide myself up here so you can see the full diagram. Okay. So synchondroses are where we have bones that are united by hyaline cartilage. Now, as you remember, often when we're looking at these diagrams in textbooks, cartilage is often shown in blue, and that's what we can see here on the bone end of the humerus, and so the bone in the upper arm where it joins the shoulder. So as you can see here, we have this blue layer of hyaline cartilage here. This isn't where the synchondrosis is. This is what is called the articulating cartilage. It's actually going to form part of the joint that we're going to use to be able to move our arm around in the as part of the shoulder. So the part that we're looking at here as a cartilaginous joint, where two bones are joined entirely by cartilage, is this line here. We met this already in our lectures on bone and bone development. This is the epiphyseal plate. So you can see here, this plate is joining the head of the humerus to the longer part here. We have the diaphysis heading down out of the view. Now, a synchondrosis can be temporary or permanent. And the one we're looking at here is that temporary hyaline cartilage joint in our long bones that contains the growth plate that allows the bone to grow during development. So this isn't going to last forever. Once the growth period is over, this will eventually fuse, and the cartilage will disappear from that part of the bone, and instead it will leave the epiphyseal line behind in the bone tissue here at the head of the long bone. This is also the kind of joint we're going to see that's going to fuse together the adult hip bones and also the vertebrae that made up the sacrum earlier in development. So this ties in with what we've seen in the lab last week, and this week we're going to look at the hip bones. So the hip bones on each side of the pelvic girdle are actually made up of three bones that have fused together. So they were held together by synchondroses that have then ossified once development has slowed down as the patient reaches adulthood. Okay, so as I said, some of these synchondroses are temporary, some are permanent. Let's look at some examples of a permanent synchondrosis. Okay, so permanent synchondrosis can be found in the thoracic cage. Here we are looking specifically at the joint between the first rib, which is running here from the vertebrae at the back to this piece of cartilage here, and then joins the first rib to the manubrium of the sternum. So remember we were talking about the sternum looking like a necktie. So this is the knot of the necktie, and that's called the manubrium. So here, the first rib is very strongly anchored by its costal cartilage right onto the manubrium here. So of course, if we look at the rest of the rib cage here, you may wonder why we're focusing on just this joint here for the first rib when we can see all the other ribs, the true ribs here are joining via costal cartilage to the body of the sternum. What's actually happening here with these other ribs, where it's joining the body of the sternum, there's actually a synovial joint occurring at each of these points. So these are actually joints that are going to allow for movement. Unlike here with the first rib, where there's no synovial joint, instead the costal cartilage here is connecting directly into the tissue here at the manubrium and into the bone tissue here on the first rib. So this means the very top of the thoracic cage is held really tightly here, so no movement can occur here. So other synchondroses can actually be seen in the thoracic cage. This is where we're just seeing a bone merging with a cartilage. So these are also considered synchondroses along here, where the rib is joining with the costal cartilages for ribs 2 and all the way down here through 10. Obviously not for the floating ribs because they're not connecting to a costal cartilage. But remember, at the other end of these other costal cartilages, we are seeing small synovial joints. They're allowing that movement of the rib cage during breathing. Okay, so I guess what should be obvious when we're looking at these synchondroses is that this form of joint is really built to limit movement, because we don't want movement to be happening here. We don't want the head of our long bones sliding across during development. And we want to keep this top of our thoracic cage very strong. So that's why we have these synchondroses here. And then when we look at their functional definition, they're all classified as synarthroses. That means joints where no movement is occurring. Okay, so now we've looked at synchondroses. Now we're going to look at the second type of cartilaginous joint. These are the symphyses. Here. So a symphysis has fibrocartilage as the connective tissue that is uniting the bones in this particular type of joint. As we know from our histology that we've been doing in lab class, from when we've looked at tissues, fibrocartilage is the form of cartilage that has much more developed fibrous component to its extracellular matrix. So there's an awful lot of thicker collagen here than we were seeing in the hyaline cartilage. Fibrocartilage is really useful for resisting tension and compression, and this makes fibrocartilage a very resilient shock absorber. And this is why we see fibrocartilage forming these particular class of joints, because we're looking at a place where we need bones to be joined together for the joint to provide strength for that union of the bone, and also to provide a certain amount of flexibility. So these are amphiarthroses. That means a joint where there's a small amount of movement permissible. And this is what we see here when we're looking at the vertebral column. Here are the bodies of the vertebrae stacked up. And here we're seeing like it cut through in a cross section. So here are our intervertebral discs that are sandwiched between each body in the vertebral column. And this disc is made of fibrocartilage. There is also some hyaline cartilage that is abutting the surface of the bone, but it's the fibrocartilage that is doing the job as a shock absorber there. Obviously, we have a small amount of movement is possible at these joints, but not a massive amount, and that's where it gets that amphiarthrosis classification. Now, another example that we'll see in our lab meeting this week is the pubic symphysis. This joins the two pubis bones, which are these anterior bones that make up the pelvic girdle here. As I was saying earlier when we were looking at those cartilaginous joints that are made of hyaline cartilage, the temporary, there are actually three bones here separated by that form of joint. Here we're looking at an adult bone, so we see the os coxa as one singular bone. But here at the front, the two os coxae are joined together by a portion of fibrocartilage, which is knitting these two together. So it can work as a shock absorber when, we said there's a lot of force working down here, onto the sacrum, and it's always trying to, push apart the remainder of the hip girdle here. And this just forms a union of those bones that can cope with the tensions and compressions that result from all of our upper body weight or torso pushing its weight down through this point of contact at the bottom of the vertebral column where it joins the sacrum. Okay, so now we're ready to move on to the third group of joints in the structural classification system. And this is the one that we think of most commonly when we're talking about joints. These are the synovial joints. They're the most movable type of joint. So all of them are diarthroses. So that's for referring back to that functional classification. So diarthroses are freely movable. As you can see here, we now have that joint cavity here. This is fluid filled and is separating the two bones that are forming the joint. So when we've looked at the previous classifications, the previous structural classifications, we've always been saying, There's no joint cavity there. Instead, the connective tissue is running directly across the gap between the two bones. With the synovial joints, we are not seeing that. There is connective tissue there, but the important thing that we see is this fluid-filled joint cavity here. Now, most joints of the body are in this structural class, especially those in the appendicular skeleton, where we want to be able to move our limbs around relative to our axial skeleton. So let's look at the general structure of synovial joints, because there's a whole series of characteristics that are common to all synovial joints. Now, first we can see here is the presence of articular cartilage. So this is cartilage that is covering the articular surfaces. So the surfaces of the bone that are coming together to form the synovial joint. And this cartilage here is hyaline cartilage. So it's not joining directly onto the hyaline cartilage of the opposite bone in the joint. The fluid cavity is separating the two. So here, this cartilage isn't working to join bones together. Instead, it's forming kind of a spongy cushion. It can absorb some compressive forces, and it's important for preventing crushing of the bone ends. So when these bones are rubbing past each other, we don't want the ends to be crushed, and that's what the articular cartilage helps with. Okay, so let's look at this special space between the bones, the articular cavity or joint cavity. As I said, these are unique to the synovial joint. Now, the cavity is defined as a potential space. And we're going to hear this a number of times during this course when we're looking at membrane-lined spaces in the body. So a potential space means there is a space there. It may not always be totally filled with fluid. It has the capacity, it has the potential to hold a lot more, and that can happen in disease states and pathological states. But what we see when we're looking in the synovial joints, in just the normal state, when we're moving this joint about, so as this bone, say, moves this way, as it moves this way, we're going to squish some of this fluid into different portions, and another part will become more emptied out, but it has the potential to refill when the bone moves back into another position across the joint. Because remember, these bones are being acted on by muscle contraction, and that's what is going to be moving them. So there is always a small amount of fluid in here, and this is called the synovial fluid. The presence of this fluid means that the bone surfaces are not directly connected with fibrous connective tissue or cartilage. And this liquid gives bones of the synovial joint the ability to move smoothly against each other. And this allows for increased joint mobility. So really reducing friction here in the synovial joint. Okay, so we need to look at the articular capsule itself. So this is the structure that is holding that fluid, the synovial fluid, in this space. So the joint cavity is closed in a two-layered capsule. So we need to come out to the sides here of the joint to see those two layers. So we have, first of all, a fibrous layer running here. This is dense, irregular connective tissue. It is continuous with the periosteum, the outer layer of the bone. So it's running continuously along here. Here's the fibrous layer of the articular capsule, and then blends in with the periosteum of the other bone across the joint. So this really helps to strengthen the joint, having this dense, irregular connective tissue running across. Now, inside that, so deeper to that, we have what's marked here, shown here in green, and this is the synovial membrane. Now, the synovial membrane is a specialized vascular connective tissue. It's a little like areolar connective tissue, but it has a certain level of organization to it that we don't usually see. And that's because of the cells that are going to be lining the inside here. The lining here is also going to cover other parts of our joint which aren't covered with cartilage. So when we get to here and we have our cartilage here, we don't have that synovial membrane. Instead, it transitions to the hyaline cartilage and runs through here. Now, we can't see it in this particular simplified diagram, but we'll see it when we're looking later on in this lecture at the knee. There are ligaments and other structures coming through here. We're going to see there are fibrocartilage pads in here as well. Now, these surfaces are also covered with that synovial membrane. This means we have lots of surface area to make synovial fluid. I'm going to talk about how that's made on the next slide. So synovial fluid is a viscous fluid. It is similar in consistency to raw egg white. It's actually a filtrate of blood, and it arises from capillaries in the loose connective tissue that we find here in the synovial membrane. So this is an unusual membrane that we're looking at here. So it isn't actually lined with epithelial cells like you might have imagined. Instead, the fluid is being pushed out of the capillaries here into a loose connective tissue that has a thin layer of kind of fibroblasts that are forming a very thin layer that goes on the deepest level of this synovial membrane. Now, as well as releasing this filtrate of the blood from those capillaries into this space here, the fibroblasts in the connective tissue of the synovial membrane are secreting lots of glycoprotein molecules. And these molecules are able to trap the available water so it doesn't get easily reabsorbed back into the connective tissue here and back into the capillaries, the small blood vessels that we find there. So this mixture of blood filtrate and the glycoprotein molecules makes the synovial fluid a slippy lubricant that eases movement and reduces friction in the synovial joint. Now, once that fluid is produced by the synovial membrane here, the fluid is not only found in this joint cavity, it also perfuses into these articular cartilages at the end. So remember that cartilage isn't vascularized. It has to get its nutrients, oxygen from nearby vascularized tissue. What happens here is the fluid that is pushed out of the connective tissue in the synovial membrane here contains the nutrients and oxygen required to keep this cartilage healthy. And it is squeezed in and out of this articular cartilage by the pressure on our joints during movement. So as we're moving this joint back and forth, the pressure on the synovial fluid allows it to be pushed in and out of the articular cartilage layers here on the ends of the bone. And this movement is called weeping lubrication. So you kind of think about, a sponge, you squeeze it, then the water comes out. If you put the sponge back in the water, it takes it back up. That's the process that we're seeing here with these articular cartilages. And this is how they're getting perfused with the necessary nutrients and oxygen they need. Okay. So we saw on the last slide that the synovial capsule is doing a good job of binding the bones together. Here we're looking at the knee joint on this slide. So we have the bones joining here, and here's the capsule running between them. So that the fibrous portion of that capsule is blending in with the periosteum of these bones here. So here we have the femur, and down here we have the tibia, and then the fibula is off to the side here. So between the tibia and the femur, we have this thickened articular capsule. And obviously that's going to provide a lot of strength, but in addition to that, most synovial joints have these things called reinforcing ligaments. Now, they are band-like ligaments of dense connective tissue that run and join with particular parts of the bones that are coming together at that joint. So we can see some examples of it here. So this one that's being labeled in green is a ligament that is kind of growing out of the fibrous portion of the articular capsule, but it's coming over here and joining with these bony landmarks of the tibia. And these are called capsular reinforcing ligaments because they're emerging out of the capsule before fusing with part of with a particular part of the bone. We also have reinforcing ligaments around joints that are considered extracapsular. So extra means outside, so outside of the capsule. So examples would be these ones that are marked in red. So we have this one here. So this is running from the femur here down to the medial sides, the inner side of the tibia here. So that's an example of an extracapsular ligament. You don't have to worry about the names of these two just yet. You will on Thursday in the lab when we look at the knee joint model together. Now, there is a third class of reinforcing ligaments, which I mentioned a little earlier on when I was talking about where synovial membrane can be found. These are the intracapsular ligaments. So these are ligaments that are running actually inside the capsule. So in this case, again, we're looking at the knee joint because that's the one that we specifically focus on in this course. And we have these ligaments here that I've labeled with the blue boxes here. These are the anterior and posterior cruciate ligaments. Cruciate because they're forming a cross, and they cross over in the middle of the joint capsule of the knee. So they're contained in the capsule. That means the capsule would be kind of running around here. So they would be in the area of where the synovial fluid is. So they are also covered with a synovial membrane, this specialized connective tissue that's going to help make synovial fluid. So they're not just sitting there as a dense connective tissue. There's also this kind of loose, specialized connective tissue forming the synovial membrane that's wrapping around these, as well as around the outer edges of the joint capsule here. So there's our three types of reinforcing ligaments. So these are going to, these band-like ligaments are going to help really hold that joint together. And you can see that here with the knee, all these multiple points of contact holding these two bones really tightly together. And here we've got, another one coming to the third bone, the fibula out here on the lateral side of the leg, so on the outside of the leg. Okay, so other general structures of synovial joints that we need to address are the presence of nerves and blood vessels. These are both really important for the functioning of these synovial joints. So synovial joints are richly supplied with sensory nerves, and they innervate the articular capsule. So they're embedded here in this tissue, that's going to be surrounding. So you have to remember this is going to be in 3D, like we saw previously on that diagram with the capsule and the intracapsular ligaments of the knee. So these nerves are able to detect pain, but they're also useful for monitoring how much the capsule is being stretched during our movements. So this is really important for sending a signal back to our brain to give us a sense of our posture and our body movements. How are our muscle contractions relating to the position our joints have now found themselves in, giving us that feedback so that we can make the adjustments we need to stay upright, to stay balanced when we're doing our daily activities. Now, as well as there being a lot of nerves coming into these synovial joints, we also have a lot of blood vessels. And that's because we need a rich blood supply to this synovial membrane here in green. Because remember, it's producing all of that synovial fluid, all of the filtrate that's forming the synovial fluid is being squeezed out of the extensive capillary beds that are found in this specialized vascular connective tissue that forms the synovial membrane. Now, each synovial joint is served by branches from several major nerves and blood vessels. So again, we are looking at the knee joint here because here's the patella, the kneecap bone. So in this cadaver tissue, we can see a lot of blood vessels coming in here and down here and into the to serve the capsule itself. Now, it's really important that we have all of this feeding in from different directions because when we're moving the joint, some of these blood vessels and nerves may be pinched upon by the compressive forces of the muscle. So this kind of organization supports an idea called functional redundancy. So that means it looks at first like we have more vessels and nerves going into this area than we really need. But we have that situation so that, say, when a movement or joint compresses a vessel, others can stay open and continue to provide that joint with the nutrients and connectivity that it needs to stay healthy and functional. This functional redundancy also helps maintain a joint after injury. If you do have an injury to, say, one side of the joint to a vessel here, you'll still have the vessels down here serving the lining of the joint cavity here, and that will continue to make synovial fluid that will fill the whole of the capsule here. So even if we have some loss of blood vessels, at a particular portion, the others can make up for that shortfall. Okay, so now that we've considered the general features of synovial joints, the things that are common to all synovial joints, we're now going to look at some special instances of structures that we see in synovial joints, but not all. One example of this is the presence of an articular disc. Some synovial joints contain a disc of fibrocartilage called an articular disc or a meniscus. Plural is menisci. These discs extend internally from the capsule so that the fibrous capsule layer is then continuous and connects in with this piece of fibrocartilage into the joint cavity. And by doing that, it completely or partly divides the joint cavity in two. They occur in joints whose articulating bone ends have somewhat different shapes from each other. So where there isn't like an exact match, that's when it is more common that we kind of fill in the spaces between poorly fitting articulating surfaces with an articular disc to make things move more smoothly. Because when we have articulating surfaces that aren't fitting well together, then only like sort of small points of contact are happening. And that means that the loading forces going through that joint can get concentrated, and that can damage the articular cartilages and possibly the bone underneath. So in order to kind of cushion where these unusual shapes are merging, we can have an articular disc in that joint. And that will distribute the load on that joint more evenly. It's filling the gaps and improving the fit between the bones. And this is going to help minimize wear and damage to the articular surfaces, the articular cartilage, and the bone beneath. These discs may also allow two different movements to occur at the same joint, by kind of allowing the one bone in the joint to glide through the joint. And that is something we see in the temporomandibular joint. So this is the joint here in our jaw, where our mandible is coming up here. Here's that mandibular fossa we looked at on the underside of the skull. And here's the condylar process of the mandible. And in between here, we can see an articular disc. You can also see the articular cartilage surfaces here. This allows us to move our jaw in different ways, and that we can open and close our jaw, but we can also move our jaw forward. I'm going to talk about these movements in a few slides time. But it's because of this disc that we have that kind of play available at that in that synovial joint. Okay, so other special structures that we might see associated with synovial joints are bursae and tendon sheaths. Now, these contain synovial fluid, just like the capsule joint itself. Um, but here, instead of filling the whole of the joint capsule, they're essentially their own little closed bag of lubricant for our joints. And they act like ball bearings to reduce friction between body elements that move over one another. Sometimes they can be seen inside the actual synovial capsule, and sometimes they occur outside the capsule that's enclosing the joint. Okay. So let's look at bursae first. So bursae is the plural, bursa is the singular. So a bursa is a flattened fibrous sac lined by a synovial membrane. And the example we see in this diagram, which I know is a very busy one, is this one here. So we're looking at this green structure here again. And over here, we're zooming in to look at it more closely. Now, bursas occur where ligaments, muscles, skin, tendons, or bones overlie each other and rub together. The example we're looking at here is is part of the shoulder joint. If you look at this picture here on the left, we can see structures that are part of the scapula. This is part of the shoulder. Here is the head of the humerus. So in this diagram here, we are looking at this structure here, the bursa. So it's called the subacromial bursa because it's lying underneath this part of the scapula that is called the acromion. And we're going to learn the anatomy of the shoulder girdle this week in our lab meeting. Just so you can get a little bit of an impression, I'm going to unblur my background so you can see my skeleton behind me. So we're looking at this bony protrusion up here, and we're looking at a ligament that's connecting it with this other bony protrusion that's just a little further anterior on the shoulder socket there. Now the bursa is sitting underneath that bony structure and underneath this ligament that's connecting the acromion to a part called the coracoid process. Underneath the bursa, at least in this diagram, we can see the fibrous layer of the articular capsule, and we can see the head of the humerus a bit lower down. Now, in the zoom in, for some reason, they've done away with the capsule. So it just kind of looks like the bursa is sitting on top of the articular surface. Obviously, that's not quite anatomically correct, but it's just to demonstrate, I guess, the idea here that the bursa is a fluid-filled sac that is rolling along in the scap. So as the head of the humerus is rotating medially, so towards the midline, this bursa is able to kind of like scroll along with that movement, and it stops friction happening between the fibrous layers here, so the ligament above and what should be the capsule below. So that's how a bursa works. So it reduces friction where a ligament or other structure would be rubbing against a bone or another fibrous connective tissue. Okay, so now we're going to look at tendon sheaths, which are a related structure to the burses that we were just looking at. So a tendon sheath is an elongated bursa. Instead of making a fluid-filled sac, instead it's a fluid-filled sac that's like stretched out, is elongated, and it wraps around the tendon the way a bun would around a hot dog. So you can see one running here um, around a tendon. And again, when this head of the humerus is moving up and down, say if somebody is raising their arm out to the side, which is called abduction. This tendon would be rubbed against by the bone, but it's not because it's protected by this tendon sheath. This helps decrease the friction caused by that bone moving in the shoulder socket. So these tendon sheaths occur on tendons that are subjected to friction. So not all tendons need these, but they're really important when a tendon is transiting a joint cavity or crowded together within narrow canals. So an example would be the carpal tunnel of the wrist. That's a place where it's quite common for tendons to become inflamed, and that's called tendinitis. So as we talked before, tendons are what are connecting our skeletal muscles to our bones, so that we can make movements occur. Okay, so now we've looked at the structure of synovial joints. Now we're going to consider the movements allowed by synovial joints. Now, as muscles contract, they cause bones to move at the synovial joints. The resulting movements are of three basic types. One movement is a gliding movement, where one bone surface moves across another. We also have angular movements, which change the angle between two bones. So you can see that in your wrist. When you're making that movement, we're changing the angle between these bones here. And we can also do rotations that occur around a bone's long axis.